it includes more than being free of disease or not feeling sick. It also includes emotional and mental health and feelings of happiness and security, healthy minds and healthy bodies. So what factors determine our health include family health history, environmental factors, and behavioral and lifestyle factors. So it's important to remember that even as planners can have ways to address environmental factors and help people have more active lifestyles or eat healthier food, there's always going to be factors such as family and health history that are difficult for planners to address. And the other part of healthy communities are the community design aspect of things. So it's important for planners to take a step back and think of community design from the view of other professions or the public at large. So when talking about community design, terms that we take for granted, such as built environment or complete streets, aren't always generally known by the public, and to be aware of that. So when talking with the general audience about healthy community design and the community design part of that, related to schools, parks, grocery stores, homes, and employment centers where people live and work and play, and also the ways that people get there on streets, walking, biking, or transit. And it includes both human-made structures as well as preserved natural environments such as parks and natural spaces are part of community design. It's always important to hit too on the fact that just the way a community can change, and it isn't frozen in time, and the community can go through a planning process to help make the community healthier for everyone. So pulling that together into healthy community design, the main goal is linking the health and planning professions to create and design communities that make the healthy choice the easier choice for everyone in the community. And I know from the planning side, we have a lot of different specialties or areas we focus on, but healthy community design is a very broad aspect, and there are a lot of different ways the work we can do affects the different aspect of health when we look at it through a health lens. And underlying healthy community design is a basis of social equity, where everyone has the ability to meet their needs regardless of race or income. And so it's important to remember that equality is not the same as equity. If the goal is to achieve a healthier lifestyle or a healthy community design, people are coming from different places and might need different resources or different types of resources in order to reach the goal of a healthier community. And with that in mind, the American Planning Association teamed up with the American Public Health Association on a multi-year effort called Plan for Health, where they conducted a lot of site-specific projects around the country, and then worked also with 28 APA chapters around the country to help promote healthy communities. A lot of these projects focused on nutrition or physical activity, and there's a lot of great resources both locally around the country as well as nationally that you can find through those resources that Sagar mentioned earlier. So I had the privilege to help manage the Healthy Communities in Pennsylvania effort, which was the Pennsylvania chapter's Planners for Health project. And thinking of the way that we worked on social equity, we quickly created an engagement ladder as our sort of main organizational framework. We were already working on healthy community design, and we were active partners. And we needed certain tools to help make that happen, but we also wanted to make sure that we gave people tools to become active partners. So contemplating partners are people who might have heard of healthy community design or might want to take action but don't know quite how yet. And they require different tools than potential partners, who are people who might have never heard of the concept or don't consider the work they do being part of a healthy community design concept. So we started by conducting a planning directors survey to all of the 67 county planning directors in Pennsylvania to get a baseline of where municipalities were and counties were in Pennsylvania. And that survey came back with a large percentage of people being actively working on healthy community design or almost active, and an about equal number were familiar with the concept but not yet acting. But there was still a large percentage, maybe 17% roughly, that were unfamiliar with the concept of healthy communities or didn't consider it part of their mission as planners. So we sought to also identify some of the priorities that we could do. Being a very broad topic, it's important to hone in on the most important aspects. So we looked at desired tools that planners needed, as well as what the most pressing needs were in communities in Pennsylvania and what strengths planners could bring to the table. So this slide shows the results of that survey element, showing in red what planners thought the greatest needs in their community were, and in blue are what are topics where planners felt they had the ability to affect change and had the tools they need. You can see that substance abuse on the opioid epidemic became a huge disparity between something where planners really felt that they wanted to affect change and it was a huge need in their community, but they didn't feel they had many tools to address it. And we can see why when we look at drug overdose rates in the United States. At this point, it is the drug overdose rate is 19.8%, or 19.8 per 100,000 population for age-adjusted drug overdose rates. And when you compare that with motor vehicle crash rates, for example, those are 10.9 per 100,000 population. So I know motor vehicle crashes are something that planners actively work hard to help eliminate through Vision Zero programs and the like. But to remember that, actually almost double the amount of people are dying from drug overdose rates right now. So here's a map of the U.S. showing where drug overdose rates are statistically higher and lower, and you can see why it was so important in Pennsylvania, but Pennsylvania is not alone. And then you can also see that drug overdose rates, unlike motor vehicle crashes, are on the rise, or not motor vehicle crashes, motor vehicle death rates are on the rise. Our motor vehicle crash rates death rates are declining while drug death is increasing. So we worked with, through a working group concept at the Healthy Communities in PA to help try to get the tools that planners and health professionals felt they needed to promote healthy community design by going first with partnering with professional organizations in our network to create topic-based working groups to create those tools. And so for the opioid epidemic, we couldn't find a lot of great research that was being done or a lot of great ways for planners to plug in, but we took this concept sort of nationally, working with the Planners for Health team, and that sort of led to this idea of doing a webinar series to help educate people on the issue, and then also hope to find some great resources that planners can use. And it's important to remember, if you want to promote healthy community design in your state, there's a lot of resources from APA, and then there are also those that the Plan for Health team reached quite a few states around the country. So there is a network of people who are involved in healthy community design that you can reach out to. So I think our next speaker is. We're going to skip to the National...
Actually, no, I'm here, Justin. Hi.
Oh, great. Okay.
I've actually just had to switch, unfortunately, to my phone since I've lost, which is crazy, I've lost internet connection 1 minute into the webinar, which has never happened to me before, but...
Great. Well,
so
next slide.
So if you wouldn't mind forwarding the slides for me, that would be great.
Okay, great.
Yeah, I will do that, Liz.
Okay, great. Great. So my name is Liz Blackwell-Moore, and I'm a public health consultant living in Portland, Maine. And I've been involved in substance use prevention and intervention for the past 18 years, and have spent the last several years working on addressing the opioid misuse problem. So if you could forward to the next slide. So today I'm going to orient the webinar series by talking about a public health view of the opioid misuse problem. And a public health approach is one that understands people's health is impacted by the people they're surrounded by, that and they're really impacted by the organizations they engage with and the community they live in and the policies that govern their community. People don't make decisions or have behaviors in a bubble. So we can move to the next slide. So I'd like you to envision a river. And a river always starts as a small stream, but it quickly gathers water from the environment around it, and it follows a path through the land, eventually leading to the ocean. And if the river is fed with clean water, fresh streams, and no major debris finds its way into the river, the path to the ocean can be fairly smooth. But if the river is fed with polluted water and trash, the river can turn into turbulent, deadly waters. And once those rapids have formed, a team of specialists may need to be called upon to help redirect the river. If the rapids have taken hold and created a really deep riverbed, it may take some time and energy to redirect the river to calmer waters. And a big river is a powerful force, so keeping that river in the new channel is an ongoing process requiring ongoing support. So like the river, people really begin life as a small child, slowly developing through the influence of the people around them and their experiences in their environment. And for some, they have mostly positive interactions with adults in their lives, and they have access to healthy communities, so their developmental stream flows rather smoothly from childhood to adulthood and beyond. But for others, they encounter many toxic obstacles along the way that can lead to serious life turbulence, like substance use disorders. And in order to find their way out of a substance use disorder, many people need the help of professionals like counselors, healthcare practitioners, recovery coaches. And the deeper the riverbed or the more turbulent the waters, the more support, effort, and time might be needed for someone to find recovery. A community of people that value and provide opportunities for wellness help people in recovery continue on a smoother life path. So today we're going to spend some time looking upriver, looking in the rapids and downriver to understand the problem of opioid misuse and to find our role in solving this problem. So if you go to the next slide. So one element that really muddies the waters upriver and downriver is stigma. And there's been greater attention paid to how language can be a part of carrying on stigma. So words like substance abuse, addict, abuser, clean versus dirty, those things can often cause people to feel shame for their actions. If you could forward the slide. As Brene Brown, a leading researcher on vulnerability and shame, says, shame corrodes the very part of us that believes we're capable of change. So you could forward. So to reduce the shame and stigma, we're trying to use terms like problematic substance use or substance use disorder or a person with a substance use disorder, a person in recovery. So this language, it not only impacts the people who are suffering from a substance use disorder, but it actually can really impact everybody and the people and all the community members on becoming a part of the solution. So people, if you could forward the slide. People become adults through their interactions with the people around them in their environment. They really don't develop in a bubble. So likewise, brains develop over time and through interactions. The actual architecture of the brain is created through a mix of genetic, experience, and environment. If you could forward the slide. So the Center on the Developing Child at Harvard University has done some amazing research on brain architecture and the development of the brain. So if we're looking at upriver, there are many ways in which we know that genetics plays a factor in people's having a substance use disorder, but we also know there are other major risk factors for opioid use disorder, and we know this through the SAMHSA, the Substance Abuse and Mental Health Services Administration, had a heroin brief that they did in 2015 that really outlined some of the major risk factors associated with opioid use disorder. And so if you could forward through the different obstacles, Sagar, that would be great. So the risk factors generally fell into a few categories that can be summarized really as early use of substances, adverse childhood experiences and discrimination, and mental health disorders. And so adverse childhood experiences are often called ACEs, and a full list of the ACEs can be found on the CDC website, but they include things like abuse, neglect, growing up in a household with a parent who has a substance use disorder, is in prison, or has died. There has been extensive research on how ACEs, and we know now that they put a person at increased risk for all sorts of health problems, including substance use disorders. And there's been a lot of research on the impact of early use of substances and how it puts people at much greater risk for substance use disorders later in life. So if you could forward the slide. So how this works when you obstacles put a person at greater risk has a lot to do with how they impact brain development. If we thought of the brain as a car, the reward system of the brain would be a lot like the gas pedal, and the prefrontal cortex would be like the brakes. The reward center is fully developed by the age of 13, and it's stimulated by exciting and risky experiences. And young people love to put their foot all the way down on the pedal. If you could forward to the next slide. The prefrontal cortex, or the front part of the brain, is really in charge of reasoning, judgment, and controlling emotions. And it isn't fully developed until about age 25. So young people often have a hard time really using those brakes. So when you add in obstacles like unresolved mental health disorders, early substance use, and unresolved trauma, they have a way of really rewiring the brain. And they rewire the brain in a way that make it more likely that a person pushes down even more on the reward center. And they can impair these different obstacles and these different toxic stress really in a person's life can impair the development of the prefrontal cortex. So as young people seek out experiences and substances that really crank up their reward system, they may also be causing damage to their prefrontal cortex, making it harder and harder for them to put on the brakes. And eventually they'll have a hard time stopping even if they wanted to, even if it's causing them and their families great harm. But brains are incredibly resilient, and so are people. And so like a car engine, it can be fixed. So we know that many people who are using heroin misused a prescribed opiate first. So you can actually just go through all three of these animations, Sagar. Thank you.
Sure.
So we know that that people use heroin, misuse a prescribed opiate first, but we also know that people who had a previous substance use disorder were 28 times more likely to develop an opioid disorder when they were prescribed an opiate by their healthcare provider. So most people won't become addicted when they're prescribed an opioid. People with previous problematic substance use are the ones most at risk for becoming addicted to opioids. So if you could forward to the next slide, if we think about what is our work in prevention, prevention is really about reducing youth substance use. It's about reducing adverse childhood experiences and the impact of ACEs on young people, increasing resilience, and improving behavioral health support. And so some specific examples of, I think, how planners can be a part of prevention is in having effective ways of talking about the problem to city leaders, changing the physical design of a community by reducing the density of alcohol and marijuana retailers, or making sure they're not in places, they're not only in places where there's sort of more high poverty, and improving community participation in public projects, and improving transportation so everyone has access to mental health providers. Prevention isn't just teaching people about the harms of drug use. Prevention is a lot of activities across sectors of the community. So now if we look in the rapids, sort of where there's really the looking into the problem of when somebody already has a substance use disorder, when people are in the rapids, we are just trying to keep them afloat. We just don't want to lose them during this time. Believe it or not, while we have seen this huge uptick in the amount of people dying, we haven't seen a huge uptick in the amount of people with a substance use disorder. It has remained relatively stable over the years. And that's partly because substance use disorders are connected to one another. What people are using right now may or may not be what people are using in 5 or 10 years. So when people are in the rapids, we have to be prepared to act quickly to meet the changing needs. Let's forward to the next slide. So harm reduction is really, right now, most people are dying from opioids, prescribed opioids or heroin and fentanyl. And so communities need naloxone to reverse overdoses. They need needle exchange to keep people from getting infectious diseases. And some cities are even considering safe injection sites. But to address the changing substance use disorders, communities also need to beef up behavioral health support and diversion programs for people caught possessing drugs. So we aren't shaming and punishing, but providing accountability and support. They need to be screened in various places, not just at their doctors, so they can have multiple places to be referred to treatment. All of these harm reduction strategies seek to keep people alive, but they also are amazing opportunities to connect people to addiction services. You can forward to the next slide. While some people can get out of the rapids on their own, for many, it takes a team of folks to redirect the river. Move forward to the next slide. So the deeper the riverbed, so when it comes to opiate use disorder, the research is really clear that medication-assisted treatment with counseling has the best outcome. And there are a few different kinds of medication-assisted treatment, with methadone and Suboxone being the most common and having the best outcome. Methadone is usually administered in a standalone clinic, and people come a few times a week, if not daily. And Suboxone can be prescribed by a healthcare provider, and it can be weekly or monthly that somebody comes in. But they both have really high success rates. The deeper the riverbed, the more time, effort, and support may be needed to redirect the river. And there are many kinds of addiction services, including medication-assisted treatment, but also inpatient, outpatient, peer support groups, and that's really because there are many paths to recovery. But people need access to them. Access includes, obviously, insurance, but it also includes transportation to the methadone clinic or the counseling office. It includes safe places to exercise and community spaces to find social connection. So people in recovery may need continued support to keep the river running smoothly and not find its way back to the rapids. Creating healthy communities, having recovery organizations that are accessible to folks, creating job opportunities for people who may have a criminal record or dropped out of school, and having safe, sober housing are important ways we can support people in recovery. So the opioid misuse problem is really a complex community problem, but that requires a full community response. Everyone has a role. So I am not a planner. So I know there'll be many good ideas presented by the next speakers and in the next 2 webinars. So this is just a list of ideas that I've come up with from my public health lens. And some of the things to highlight are really around the consideration of the behavioral health system when doing transportation planning, using national certification standards for sober housing, doing greater outreach to previously marginalized communities in the community development process. And this really might entail doing a lot of upfront work to understand what are the barriers, what is the community trauma that people may have experienced in particular communities in order for that outreach to be successful. And other ideas, integrating strategies with community development funding. So, it's one thing for us to know what the evidence-based strategies are, but it's another to get the communities and leaders to buy in to and adopt the evidence-based strategies. And there are research-based ways of talking about the problem. After years of trying to find the right messaging, the right opening statements to get the public to think about substance misuse as a community problem, not as a moral failing of individuals, I finally stumbled upon Frameworks Institute. And Frameworks has done great research into how to frame social problems to move the public's understanding closer to that of experts on the topic. So when presenting new strategies like a new location for a needle exchange or changing a police policy to divert more people to treatment rather than jail, talking about brain development and the root causes of substance use disorders is an important part of helping the public understand the problem. So using the river metaphor helps move people away from blaming individuals and having a fatalistic view of the problem to understanding the whole picture and seeing their part in the solution. So as you come up with new strategies to implement in your communities, I suggest working with your partners in public health and city government and policing to create some consistent talking points that include some of these ways of talking about the problem. The Center on the Developing Child at Harvard University has incredible short videos that can explain brain development and ACEs and resilience. And the Framework Institute has short videos on the river metaphor. And I can tell you from experience that this framing of the problem will help build public support for your efforts. People who may have seemed like adversaries may suddenly become your biggest champions because they now see the problem differently. So I've included a list of resources and links that I've mentioned throughout the presentation. And this page is mostly about communication and prevention resources. And then the last slide, Sagar, if you could forward to, this page is mostly addiction services and recovery resources. So I just want to thank you all for attending the webinar, not just for attending it, but really for having the vision to see that you are also a part of the solutions of this problem. Because the more sectors that we engage in thinking about this problem, the more success we will have in solving the problem. So thank you very much.
Thank you, Liz. Justin?
Yes. So I think we're on to Brian and Hadi.
Great. Thank you so much, Justin and Liz, for that great overview. Again, my name is Brian Bowden with the National Association of Counties. I cover our health policy and advocacy portfolio here, and I'm going to be joined by my colleague Hadi Sadai, who does the same for justice and public safety, and has been leading a lot of the work we've been doing with our sister organization on this issue. So a quick overview of NACO and counties. So the National Association of Counties, or NACO as we will say for short, since 1935 has really represented over 3,000 counties, parishes, and boroughs across the country to really advocate around the collective voice and to be the voice in Washington for county government. Our vision actually is creating a healthy, vibrant, and safe counties across the United States. So directly in line with some of the work that we've been talking about here. Most people, around the country have heard of counties, but what we often find is county government is not understood very well, and counties themselves. When we think about counties, we like to point out that half of the country's population lives in 120 of the largest counties, LA County, San Diego County, Dallas County, so your large counties with population is over 500,000. The other half of the population lives in much smaller counties. About 2/3 of all counties have populations below 50,000 people. So various sized counties, and as many of you know who work in city or county government, all local governments are slightly different, but there are some commonalities. So I'm going to quickly walk through, Liz set me up nicely because counties are really involved in many of those sectors that Liz mentioned, everything from transportation to community economic development. But for the purposes of this webinar, I'm going to focus on health human services and justice and kind of highlight counties' role. So counties invest about over $80 billion annually in community health systems. Counties were the original safety net. They still support over 900 hospitals across the country, with hospitals like Parkland Hospital in Dallas, Grady Hospital, Atlanta being the most well-known county hospitals, but also in a lot of our rural counties across the country. About half the state, behavioral health, so mental health use, is still county-based. And then about 2/3 of our local public health departments are still based through our county. And I put it on this slide too, the importance of Medicaid. Again, counties, even before the Medicaid program came to be a little over 50 years ago, counties were that original safety net. There actually used to be a lot more county hospitals than there are now. Medicaid has been really crucial in helping counties meet their obligations. A lot of states require counties to provide some sort of health care to uninsured or underinsured, so they actually have state statutes that require counties to provide care. Medicaid certainly helps with that. And for those that don't know, 21% of all healthcare spending on substance use disorders is through Medicaid. So a vital source of coverage for this issue, especially in states that have expanded Medicaid. What people often don't know as much about or forget about, especially in relation to the opioid epidemic, for those of us that come from a health background, is the role of both justice and public safety and human services and the impact this is having on those sectors. I said counties invest over $80 billion in health. The figure for justice and public safety is pretty similar, about over $90 billion. Most people think about they're either mainly sheriffs, but also some police departments in our counties. But besides, I guess, your county fair, most people associate with the county jail. There are approximately 2,800 local county jails. That's the majority are county operated, and they annually admit 11.4 million individuals. So for those, we often talk about prisons and jails. So prisons being run by the state, being for longer sequences of time, but jails being for more minor offenses with an average length of stay of 23 days. So you have folks staying for shorter times, and unfortunately, many people falling through the cracks and ending up in jail that happen to have a substance use disorder or a co-occurring mental health disorder. Also, counties employ first responders and, importantly, operate court systems, including drug courts, so prosecutors, et cetera. That whole infrastructure there that counties are involved with that are directly impacted by this epidemic. Also, I want to highlight human services and counties' role footprint there, because that's where we're hearing a lot from our folks on this epidemic. In over 12 states, counties administer child welfare services who are really being impacted. And most counties operate child protective services and foster care. And just to give an example, in Ohio, a strong county state, their foster care system costs are expected to increase by more than 2/3 just in this next year. So we're really hearing that you have grandparents raising kids when parents are taken away. So this epidemic and this issue, while it may at first impact kind of what we think of as our typical public health or health system, it's definitely having impacts across sectors at the county level, and so we're looking at it from kind of that holistic viewpoint. And I guess there's the human toll that we all know about and that our county officials hear about, but clearly there's also an economic consequence of the epidemic that we hear about from our counties. Counties are really limited in how they raise new revenue. Typically that's through property taxes, and most states limit either how fast or how much counties can raise new revenue. And again, across health, justice, human services, their budgets are really being impacted with not a lot of federal funding right now for this. we learned early on, and those that have been involved with this issue, given the complexity of this issue, as both Liz and Justin mentioned, it really requires coordination across multiple agencies at the city and county level, at the local level, and very clear leadership. And we've seen those champions at the local level look a little bit different across the country. Many times, it is a county commissioner or an elected county supervisor, but it's also a county sheriff or someone else who's really respected or trusted in the community. So, right when this epidemic started to take off over the past 5 years, at the National Association of Counties, we were hearing about this issue from our members and realized that we needed a different approach. We're kind of structured internally by issue area, but because this issue cuts across areas, and it's not just a county issue, it really involves like a coordinated local issue. We took a slightly different approach on this issue than we do on many other issues. And to talk about that process and what's come out of that and where we're going from here, I'm going to turn it over to my colleague, Hadi Sadai.
Thank you, Brian, and thank you to the Planning Association for hosting this great conversation. And we certainly hope that this is the beginning of a greater partnership in our work and the work that you all are doing in your communities. As Brian mentioned, we have taken a somewhat atypical approach to dealing with this issue within our organizational work, and I'm going to lay that out for you all a little bit, and hopefully it's helpful as you formulate your local efforts as well. In 2016, the picture that you see there is the task force that we put together. We called it the National City County Task Force on the Opioid Epidemic, and we brought together 10 city officials, mayors, city council members, police chiefs, firefighters, etc., and 10 county officials. And our task was to comprehensively study an issue that had come to the forefront for both of our organizations through our members reaching out to us and telling us, this is really straining our communities and our governments in every conceivable way. So our task was to assess the opioid epidemic, how it was impacting local communities, and to come up with a set of recommendations, mostly aimed at local officials, but also for state and federal partners to inform their response to this epidemic. And ultimately, the report that you see there, which is available at opioidaction.org, was the culmination and final product of our work. And in order to arrive at these recommendations, we spent pretty much all of 2016 in conversation, not only among the task force members, but also with other city and county officials, with state officials, with federal officials, and also with local officials of all different stripes, with prosecutors and public health directors and county managers. And the reason we made that conversation so broad was that we really wanted to understand what parts of the community the opioid epidemic was impacting, and it pretty quickly became apparent that there were very few parts of many of the most impacted communities that were not being altered in some way by this epidemic. So to kind of give shape to our work, we focused on 4 buckets of recommendations. The first is leadership, which we thought was a sort of a unique part of the task of local officials in this epidemic. We talked about how local officials had both the authority that came with public elected office, but also the familiarity with their communities that came from being at the local level rather than at the state or federal level. And we called on them to kind of use that unique position to really set the tone on these conversations. And then the other 3 buckets that you see there, numbers 2 through 4, are sort of the traditional categorization of the response to this epidemic. Prevention and education, sort of jamming the revolving door to make sure that further individuals are not becoming addicted as you work to provide treatment for the individuals who are struggling with addiction. Treatment, obviously, and then public safety and law enforcement to ensure that you are fighting against the illicit forces and sometimes the overprescription that are driving factors of this epidemic. So on the first bucket of recommendations, as I mentioned, we really found that stigma was a huge part of this epidemic, and we found that stigma was preventing individuals struggling with addiction from seeking help. So one way to look at it is you might be struggling with a prescription painkiller addiction, and if you feel that you are going to stigmatize yourself in some way by seeking help, that painkiller addiction might turn into a heroin addiction, which now has a new set of risks for not only the individual and the family, but also for the local government when it comes to hepatitis C outbreaks and that sort of thing. And we found that stigma was also affecting, and I think this is relevant to you all, was also affecting the ability of communities to establish physical locations that would help to address the opioid epidemic, whether that would be a methadone clinic or a clean syringe exchange program or what have you. We found that there was a lot of pushback at the local level on that sort of thing, and that local leaders could play a huge role in addressing that stigma. And then I think the other big piece of the leadership puzzle for us was the role of local elected officials as conveners of bringing to the table all of those individuals that I mentioned, from public health to law enforcement to planners and county managers to prosecutors and educators and literally anyone who works with a population that is impacted by this epidemic. Bring them to the table and start all of your conversations there. So I think that is kind of a fundamental underlying recommendation that we had throughout this report, was that to understand what the epidemic looks like in your community and what response is your best bet of getting out of it, you need to bring together local leaders and start all of those conversations there. The next bucket of recommendations that we had while we work on loading this next slide was related to prevention and education, and that certainly, I think, splits into a couple of different areas that are a huge part of this conversation. And one part of it is the education piece, just ensuring that this sort of culture of painkillers being perceived as sort of a fun thing to dive into after you have a root canal. I certainly remember as a kid having some sort of small medical procedure and then joking with my friends about receiving a oxycodone prescription or hydrocodone or whatever it might be. And that sort of culture of not treating prescription painkillers and opioids as products that could very rapidly lead to a heroin addiction, not making that connection of how deadly serious these products can be, is something that we have worked with our members on kind of reversing. So public education, awareness of the dangers of opioids, awareness of proper disposal was certainly one side of it. And on that note, kind of working with counties to help them understand that you need to help diminish the supply of drugs that are in your county and helping to feed this epidemic. So one part of it, as I mentioned, is obviously on the law enforcement side that I'll get to in a moment, but also just in people's homes. Like, are you aware of the proper way to dispose of medications? Are you aware that it is a risk to your family, your kids' friends, and their families to have oxycodone just sitting in your bathroom, accessible to anyone that might drop in? And counties obviously play a big role in that sort of supply decrease through take-back days and safe disposal sites, and there are a lot of interesting questions of where those safe disposal boxes should be located. Should it be in a county building? Should it be in a sheriff's office? Should it be in a CVS or a Walgreens? Where is it most effective? And how do we work to limit the risks that come along with having a box that has a bunch of opioids in it during the opioid epidemic? So those are some of the prevention points that we hit on. And again, one of the things that we sometimes struggle but always work to address with our members is even in the heat of the escalating opioid epidemic, even as individuals are tragically dying, if you take your eye off the prevention and education side of things, we're never going to be able to get out of this, because you need to stop the new dependence from developing before you can truly solve this epidemic. And then working through these next items a bit more quickly, because I think these are some of the more traditional solutions to the opioid epidemic that you have doubtlessly seen in your work. Naloxone, I think, is in a odd way one of the success stories of the opioid epidemic. Getting naloxone into more hands, local governments and counties working to ensure that not only individuals struggling with addiction, not just first responders, but all who come into contact with individuals who might be experiencing an opioid overdose have access to naloxone. In some places, that's public libraries and the librarians having access to naloxone. In other places, it's jail staff. In other places, it's families of individuals. Baltimore is a model sort of example of this sort of work of making sure that this naloxone, which is in its own small way can help to prevent overdoses and fatalities, is in as many hands as possible, and in hands that are aware of how that drug should be administered. And then the other items, medication-assisted treatment, it is difficult to overstate the importance of that, the medically proven, the scientifically supported treatment to opioid addiction. So we certainly worked with our members to make sure that they understood why these are the scientifically backed treatments of this epidemic and how they can help facilitate them within their communities. And then lastly, we talked about law enforcement solutions. One of the core convictions of our work was that we cannot arrest our way or incarcerate our way out of this epidemic. But at the same time, we knew that local law enforcement and state and federal law enforcement was a huge part of this, and that we would never be able to turn the tide without their help. So what is the proper balance in helping divert individuals out of the justice system and making sure that the justice system still has that deterrent quality of enforcing the law in ways that will limit supply of opioids? And there's a lot of cross-state and cross-county and city collaboration that plays into that as well. So our last slide here, and we're certainly happy to address any questions that you all might have, is just about our work going forward. We are in pretty much constant communication with Senate and House offices that are working on different pieces of the legislation that address this issue. We have convenings on this issue at pretty much all of our events, and I think the last thing I'll say on this piece before passing it momentarily back to Brian is that we are always happy to partner with you all, whether that be individual conversations about your community or with the Planning Association as a whole about how counties and planners can partner moving forward. So I'll pass it back to Brian quickly before we wrap up our part.
Sure. Since I think we're short on time, I'm happy, Justin, to turn it back over to you, and maybe we can do everything else through question and answer.
Sounds good. Great. So I'm going to moderate the question and answer period, as I'm a good stand-in for planners looking to get involved in the epidemic and not sure what to do. So submit your questions through the box. We have a couple already in, and also want to point out on this slide that this is an emerging topic, and if you are doing any work related, please let us know. So there are a couple questions related to rural communities and how some of these suggestions relate to rural communities that have minimal services, limited public transportation, and treatment centers being fairly far away, and if there's any specific funding sources for rural communities.
Yeah, so I have some thoughts on that because I live in Maine, which is obviously has lots of rural parts in it. And one of the ways I've seen other rural communities deal with this is Suboxone is an incredibly it's an incredible treatment for people with opioid use disorders that is prescribed through a physician's office. So most rural communities have some physician's offices, and so I've seen different people having different solutions to the problem. Where people have used in Vermont, they've used this hub and spoke model where there's a hub where people go to seek treatment for their initial getting onto Suboxone and doing some of the initial work, and then they can continue their treatment through their primary care provider. And so getting the primary care providers to get connected with a behavioral health person is kind of a different problem. Some of them you need to have kind of ongoing counseling often to be doing Suboxone treatment. And so I've seen here in Maine, they've been using GIS mapping actually to find people who are primary healthcare providers and match them with behavioral health providers so that people can get both of their needs met to be able to use Suboxone as a treatment.
Great. Another question relates to, and I think this is for the NACO reps, the idea of this being declared a public health emergency, which might open federal dollars. Are you aware of status on that, or any background information on that?
Sure. This is Brian, and yeah. So President Trump declared this epidemic a public health emergency, and actually just extended that declaration that I think was for 90 days originally. That just pretty much allows the Department of Health and Human Services to move around kind of staff and internal funding. The funding out of that, like, very, very small. So there's really not been new additional federal dollars for this epidemic. The task force, or the commission, White House commission, really kind of put that in Congress's hands, and we do hope that when they have to kind of do an appropriations package to keep the federal government open, that potentially there will be some additional resources for the opioid epidemic. But given the scale of the problem, it's likely to not be enough.
Yeah. And I think another legal question, just quickly, was addressing sober living facilities and how that relates to the Fair Housing Act, how we can license and encourage responsible sober living facilities without superseding the Fair Housing Act. Does anyone have any thoughts on that?
This is Brian. One of our colleagues that's not on the webinar is a little more into housing issues. I mean, I would highlight for this audience, I mean, that is a key issue that we've heard of, and we've also heard from counties specifically in Florida and some of the western states of, there are some bad actors in this space. So this is a hot issue right now about what constitutes an appropriate sober home and how you zone for that in communities, et cetera. So some of you may be facing those issues.
Great. And if anyone listening has experiences, talk to Sagar, and I'll turn it over to him for wrapping things up.
Thank you, Justin. Again, please feel free to contact any of the speakers if you have any follow-up questions. Their email addresses are on the slide. And I would like to thank all our speakers for the wonderful presentation. And I'm sure we have a better understanding of the opioid crisis now than before. Thanks again, and thank you, Justin, for moderating the Q&A. I would like to again remind everyone that you will receive a link to the recorded webinar in your email soon. And with that, I will officially end the webinar. Have a good rest of the day. Thanks.